Hello, welcome to another video segment on medical assisting skills. This one we're going to be talking about phlebotomy. So for my students looking through this is chapter 31 from your medical assisting textbook, Today's Medical Assistant. Introduction to phlebotomy. We have to talk about what is a phlebotomist and why do phlebotomy to begin with. When you look at the word phlebotomy, we have the suffix of the word tomy, which is meaning an incision made into the body, and then phlebo, the combining form in the word phlebotomy, refers to blood, and more specifically like blood in the veins. So phlebotomy just means incision of a vein for the removal of blood. We do phlebotomy. A phlebotomist performs phlebotomy to collect a blood sample, and not just for fun, right? To collect a blood sample to send it to a laboratory for laboratory analysis. Your phlebotomist, that's that person who specializes in the collection of blood samples. Now, as medical assistants, you are not going to be a phlebotomist. Now, that you can go and get separate certificates in phlebotomy, but in our medical assistant courses, we don't teach a full phlebotomy course as well. So let's learn what a phlebotomist does and what somebody who may be just venipuncture certified does. So a phlebotomist is again the individual that collects these blood samples, and there's more than one way to get blood out of the body. We've got blood is in the blood vessels, so we have to get the blood from a blood vessel. We have vessels leading away from the heart, back to the heart, or vessels that are sort of in the in-between. So a phlebotomist would be able to perform an arterial puncture. Those are usually only done in a hospital setting. Some important differences for the things that would for our blood in our arteries is that blood in our arteries is on the path away from our heart. And with the exception of pulmonary arteries, arteries always carry oxygenated blood. So if you need to assess carbon dioxide levels, oxygen levels, or acid-base balances, then you'd need to perform an arterial puncture. And that has to be done under a little more stringent, a little more aseptic guidelines than we would practice for venipuncture. So we just don't do that one. That's going to be left to the phlebotomist. But as medical assistants, you'll be venipuncture certified. And so venipuncture is the incision of a vein for the removal of blood, whereas phlebotomy is more broadly just the incision of a blood vessel for the removal of blood. So venipuncture. Veins are on the path back to the heart. It's our blood in the same way there's blood in our arteries, but this blood in our veins is deoxygenated. It has deoxyhemoglobin, which is a way to say our red blood cells, which contain hemoglobin, have lost their oxygen. Their oxygen has hopped off and gone to the places it needs to go. So blood in our veins on the path back to the heart just is deoxygenated, and that's okay, because for most tests we don't care about that. For a lot of tests, everything except for these oxygen levels, carbon dioxide, acid-base balances, for a lot of tests we just don't need a specimen that contains oxygenated blood. So that's okay. What we're looking for on most of these tests are, to do things like a blood count, to look for hormone levels, cholesterol levels, lipid levels, electrolyte levels, just a number of things that we don't need to puncture an artery for. Turns out it's easier to puncture a vein than an artery. Arteries are under a high amount of pressure. They pulsate. They're thick-walled. They tend to bleed a lot when we puncture them. Whereas veins, they bleed more slowly. They're under less pressure. It's a steady pressure. And we can stop the bleeding more effectively from a vein. So it's easier to take blood from a vein, and we don't care about the oxygen and carbon dioxide acid-base balances like we would for an arterial puncture. So venipunctures are the broadest category of of things a phlebotomist would do, and as medical assistants you'll obtain a venipuncture certificate after at least 10 successful draws on your partner or patients. Skin punctures. Skin punctures are also referred to as capillary punctures. Are the incision of many capillary vessels for the removal of a capillary blood specimen. Capillary blood is sort of special. It's that in between where blood goes out to the cells through our arteries, and then before it comes back to the heart, blood's going to move through capillary vessels. They're extremely tiny vessels, finer than a human hair, and they don't necessarily carry oxygenated blood. They don't necessarily carry deoxygenated blood. It's sort of a mixture, and that's what we call our capillaries, or in this case, skin puncture. So the biggest category here is venipuncture. So to kind of lay it out, let's talk about the methods for venipuncture. The most convenient, fastest, and most often used method is called the vacuum tube method. It's the use of an evacuated tube, glass or plastic, which contains a vacuum. I sort of like to explain vacuums to people as, everyone knows what a vacuum is. We have a vacuum in our home. It sucks in air or dirt and all the grime from your carpet. But what a vacuum actually is a chamber that inside of that chamber, the pressure inside of that chamber is lower than the atmospheric pressure outside of the chamber. So what we have here is a tube that has all the air, all the atmosphere sucked out of it, and it's in effect empty on the inside. We call that a vacuum. So if we were to introduce a needle into that tube and the other end of that needle were in a vein, it would prompt the blood to flow into the vein because the blood is under pressure and the inside of the tube is under less pressure. So it's all to do with pressure differences. The vacuum tubes are great because we puncture the rubber stopper, blood flows in till the vacuum is exhausted, and then once we remove the needle from that rubber stopper, the tube is sealed. And so we've got a way to collect the sample, collect the right amount of sample, and then have the sample be sealed for transport. So the vacuum tubes become the most common, most widely accepted method of obtaining the blood specimen and transporting the blood specimens. Alternative methods may be butterfly needle and syringe. Butterfly needles, essentially, we'll go over them, but they are essentially a long tube with a puncture needle on one end and a tube puncture needle on the other end, with the tubing being about 12 inches long. This works great for difficult draws because you can maneuver the angle of the needle a little bit more effectively because it's not directly attached to a tube holder. This also works great for small veins because using the syringe instead of the vacuum tube allows you to control the amount of vacuum you're creating so that you can keep a vein from, for example, collapsing. Or if a vein does collapse, you can let back on the vacuum, stop pulling so much vacuum to allow the vein to reopen so you can continue the draw. So it's a little bit a way to perform the venipuncture in a more controlled way for difficult patients, so small veins or sclerosed hardened veins. Patient preparations for venipuncture. The most common patient preparation is fasting. Not all laboratory tests require fasts. A fast is just defined as abstaining from food or fluid except for clear liquid water for a certain amount of time. Somewhere at least 6 to 8 hours, more commonly 12 to 14 hours. That's the most common one. Other common ones may be the avoidance of a medication, but as medical assistants, we need to make sure we understand that we never make a decision on what the patient's preparation should be. We go off of physician guidelines or established clinical protocols for what the patient preparations are. A great example is a comprehensive metabolic panel. one of the tests on there is like a glucose, and you have cholesterol tests, and if you, for example, eat, those test results will show abnormally high. If you are not fasting, you may have abnormally high test results, and that's a concern. So and it's definitely a reason to say that test result would be inaccurate. So at bare minimum, we can say if you don't do the right preparation, the test results may be inaccurate. It's the patient's responsibility to follow the instructions, but it's the medical assistant's responsibility to verify that the patient has followed the instructions. So that's something to think about for us. We need to make sure that we are able to prepare them for the test, tell them what to do, and when it's time to perform the venipuncture and draw the sample, we need to make sure that the patient is ready to have that sample drawn. So make sure they've prepared properly and understand what tests require which types of preparation. Again, the most common being fasting or avoidance of medications. Collection supplies. So before you perform your puncture, after you've determined what tests have been ordered, and before you go greet your patient and actually do the job, put your equipment together. Okay, so your collection supplies, you have your vacuum tube, or you have your syringe and butterfly, you have your needle apparatus, you have your tourniquet, you have your lab requisition. All of your supplies should be put together before you go in to draw the blood. That includes knowing what type of specimen you need. You choose the type of blood specimen collected based on which tests are ordered. You have clotting tests that are ordered, you have blood counts that are ordered, you have metabolic panels that are ordered, thyroid panels, a number of different tests that are ordered, and different blood specimens are required for those. For example, we would need serum if we were going to test the thyroid level, thyroid stimulating hormone, or if we were going to perform, like I've been saying, a metabolic panel. It's all done on serum, so you need to know the type of specimen you're supposed to collect. You have a laboratory directory in your office where you work that will tell you which types of specimens to collect. It's listed alphabetically by the names of the tests, so go to that, learn from that directory. That's your best resource for knowledge inside the clinic when it comes to collecting lab specimens. In that directory, it will also tell you the amount necessary for laboratory analysis. Do we need 5 mLs or 10 mLs? Typically, it's about one tube per test. Now, the tubes come in different sizes, so that's variable, but around 1 tube per test. Make sure you choose the right tube so you collect the right type of sample. Then your technique for collecting your specimen. This comes back to, do you want to use a vacuum tube, or do you want to use a butterfly and syringe, or would you like to try to use the butterfly needle and the vacuum tube? That's another possibility. So the right technique. Lastly, proper handling and storage of your specimens. Most vacuum tubes require inversion after the puncture is done. After the blood has been drawn, they require inversion, and that's so that we can coat the additive coat the additive that's on the inside of the tube on the blood, and that way the blood is preserved in the way that we want it to be. Anticoagulated, or clot stimulated, or whatever it's usually an anticoagulant, whatever the preservative or additive is that we want. Make sure that gets done, and make sure we're doing things like storing the tubes upright when we're asked to. For serum tubes, we have to let them sit upright for a specific amount of time and then centrifuge them. All blood tubes require some version of storage, and it's usually just refrigeration within a certain amount of time, or testing within a certain amount of time. But you have to consider handling and storage after the specimen has been taken. Okay, with regard to patient position, so you've put your equipment together, you know what samples you're taking, and you go to address your patient with all your equipment. You need to choose a site. We're looking for veins, and while we do have many surface veins in various areas on our body, most of them are either small and close to the surface, big and deep down under the tissue, or some other version. What we're looking for are veins that are large and close to the surface. Okay. A third requirement would be that the vein is well anchored on either end, but that can be, we can work around that. But there's a site on the body, the anterior of the elbow, called the antecubital space, which is the most common site for venipuncture. This is the one that's easiest to access with, as long as your patient can roll their sleeve up, has a short sleeve shirt, or can just remove that arm from that sleeve of their clothing, we're going to be okay. We can get to the antecubital space really easily, we can get to the hands easily too, but the veins are not well anchored there, so they're harder to work with. The antecubital space is our spot. The best position is seated. What seated allows to happen is seated allows the patient's arm to be in more of a downward position. What this allows, one, it allows the arm to be straight. Two, it helps the blood pool up in the veins because the blood has to travel up the arm to get back to the heart, so it makes it easier for the veins to become engorged. And three, it helps with something called venous reflux, which I'll talk about in just a moment. But the arm should be straight, palm up, elbow should be straight. One thing you can do is actually take your patient's opposite arm, have them make a fist with the opposite hand, and stick that fist under the elbow, and that will help to extend the elbow that you are trying to use for the puncture, so that their elbow is straight and the veins are forced close to the surface of the skin. So I mentioned venous reflux. Venous reflux is what happens when blood flows from the evacuated tube back into the patient's vein during a procedure. There are additives in the tubes, and once the blood mixes with the additives, if any of that blood moves back into the veins, that makes an issue. Specifically, there is potential for puncture site reactions or very severe adverse allergic reactions, and this is patient to patient, but it's possible. So you have to consider this, and we should try to minimize venous reflux. You do this by keeping the patient's arm in a downward position. The evacuated tube remains below the venipuncture site, so the tube fills from the bottom to the top and is not filling from top to bottom and potentially adding blood back into the body. This sort of contradicts my personal preference on venipuncture, which is to have my patients in the supine or semi-recumbent position. At least in semi-recumbent, we can put the arm in a downward position, but supine positions don't allow for this so well because the patient's arm is parallel to the floor, so the venipuncture apparatus is going to be angled a little bit upward. And that's okay. That's okay. If you're concerned for your patient's safety is first and foremost. So if you're concerned for your patient's safety, they may faint during a venipuncture. It is most correct to have them in the supine or semi-recumbent position so that we avoid mechanical injury if they do faint. And we can talk about fainting in a little while, but right now venous reflux is a risk if you don't have if you have the tube filling from the top to the bottom rather than the bottom to the top. Your tourniquet. Tourniquet's one of the most important pieces of equipment. It allows the veins to stand out during the venipuncture, so they're easier to palpate, which and this slows down. The reason why it makes the veins stand out is because it slows down venous blood flow, and the blood pools in the veins in the area distal to the tourniquet. Remember, blood's traveling up the arm. It makes the veins more prominent. So more visible. The walls of the veins get stretched out and the veins get larger, and it makes them easier to palpate. They don't have to be visible to perform the puncture. You can perform venipuncture on a palpated vein even if you can't see it. So palpation is more important than visibility. If it's visible, it'll be palpable. But if it is not visible, it may still be palpable. Your tourniquet guidelines. Don't apply the tourniquet over sores or burnt skin. The tourniquet should be around 3 to 4 inches above the bend in the elbow. You can hear my voice, I'm a man, so my hand's a little bit larger than average, and my hand's about 4 inches wide. I like just to tell people, use their hand as a guideline. The width of the body of your hand is about how far up above the elbow the tourniquet should go. And you're placing the tourniquet approximately midway up the upper arm. This gives you plenty of room to clean the site and perform venipuncture. Never leave the tourniquet on for longer than 1 minute. It's, for one, uncomfortable, but that's not even the important thing. It causes the venous blood to stagnate, causing venous stasis. This is when blood stays in one spot for too long. The plasma from the blood can leak through the tissues of the vein into the extravascular space, the space around the veins. So we have extravasation of blood plasma, which in turn causes the blood inside of the veins, the stuff left behind inside of the veins, to become extra concentrated. So you would have abnormally high test results, like your blood count would show abnormally high. Hemoconcentration, increase in the concentration of blood components due to extravasation because of venous stasis. This is caused by, again, a decrease in fluid content of the blood, and it will alter test results. Always remove the tourniquet before removing the needle. This is a must do. I have seen blood, come out at a pretty rapid trajectory, pretty good trajectory. I've seen people get squirted in the neck, in the chest, in the face with blood if they do not remove the tourniquet. So most of the time we talk about a hematoma, some blood coming out onto the surface of the skin, but in a lot of cases the blood's under enough pressure. If you remove the needle when the tourniquet's still on, blood may squirt, and that's a risk of a blood exposure, bloodborne pathogen exposure. Remove the tourniquet before you remove the needle. Even in an emergency, it's a must do, and this is why we use a quick release application of the tourniquet. So we just need one hand to release the tourniquet. If your tourniquet's reusable, disinfect it, or just throw it away. As I stated before, our site selection, we want to go for the easiest to access veins, which are the antecubital veins. It's easy to draw blood from there, especially with patients with large visible veins. It is difficult to draw blood on people with small veins, like patients who are just small or have small veins, patients whose veins are deep, patients who are dehydrated, which all falls into that category of veins that may not be able to be palpated. And you've got to be able to palpate a vein. If you can't palpate it, can't see it, then you need to choose another site on the body. So the antecubital veins, there's three. We've looked at the diagrams for them, but the median cubital is the best. It's the middle. It's large. It's the largest. It does not roll because it's anchored very well on either side, and it's anchored in so that it's short and less chance of it rolling out of the road. It's in the middle of the antecubital space. Sometimes it lies deep in tissue and cannot be palpated. And I would, again, never recommend doing a blind stick. Just flying blind, trying to poke the vein, knowing that it's lateral to some tendon or something like that. We wouldn't do that. Okay, we don't just blindly stick and fish around. We puncture veins when they are palpated and or visible. Also, don't perform venipuncture if there's an area that's been scarred from repeated venipunctures. That's just bad for the patient, makes it more difficult for you. Your numbers 2 and 3 for best veins in the antecubital space: basilic, which is medial on the antecubital space, and cephalic, which lies lateral on the antecubital space, should be used when the median cubital is not available, not palpable, can't find it, can't see it. Cephalic, thumb side; basilic, pinky side. They both roll. Basilic more than cephalic, but they both roll. They're both smaller. They're both they are more difficult to draw blood from than the median cubital. So if you can avoid it, do. Also worthy of note, next to the basilic vein, there's a artery called your brachial artery. Now, the big functional difference between arteries and veins for palpation is that arteries are usually larger, thicker, and they pulse. That's the big difference, is they pulse. You put a finger on an artery, you feel the bump, bump, bump of the pulse. Whereas veins are just kind of squishy, bouncy things. They don't pulse, they have steady pressure. So if you palpate something and it's pulsing, do not do the puncture there. It's an artery. The brachial artery is deeper in the tissue than the veins are. It pulsates, it's more elastic, and it's thicker. If you happen to do the puncture there, you may notice that the blood will be bright red and it will come out in spurts. This is a key that you've punctured an artery, and you should remove the tourniquet first, then the needle, and then apply pressure with sterile gauze for around 5 minutes. Remember I said earlier, arteries are going to bleed for longer than veins do, and it's harder to stop the bleeding. So steady pressure, steady, firm pressure for 5 minutes at least. As you're palpating for veins, don't be afraid to palpate many areas on that patient's arm. Don't just go to the antecubital space. Check out the dorsum of the hand, check out the lateral wrist, check out the forearm. When you're looking for veins, you want to use 1 or 2 fingers. I like my second or third fingers, that's index and middle fingers, and I like to extremely lightly palpate. The harder you push, the less you're going to feel. Okay, so very, very, very lightly palpate the veins. I like palpating laterally across the arm till I find a vein, and then I once I find it, I roll my finger back and forth over the vein to help me determine the size, depth, and direction of the vein. You should check that vein as you're palpating it if there's any issues with it. Does it feel small? Is it too small to do the puncture? Is it sclerosed, hardened? Is it bumpy because of, scarring or something like that? Or is it like flattened down because of the way because of your patient's anatomy? So check it for issues. You want the biggest, most prominent, easiest to access vein. So some things that you can do to make the veins a little more prominent. Some I like, some I don't like from here. One I really do like to start with is take the tourniquet off, have the patient hang their arm over the side of the chair so blood sort of pools for a couple of minutes. Reapply the tourniquet, reattempt palpation. Number 2, tap the vein sharply with the index finger and second finger. It's that slapping the vein that you see done in all sorts of medical TV shows and movies and so forth. It works. It agitates the skin a little bit, increases blood flow to the area. The vein becomes a little more engorged. Gently massage the wrist the arm from wrist to elbow. This is the same concept. Increase blood flow to the tissues around the veins, hoping to help the veins stand out a little more. And lastly on here, apply a warm, moist washcloth for 5 minutes, which will dilate blood vessels and improve blood flow. All of these improve blood flow and allow the veins to be more easily seen. Okay, lastly, if you have done all of this, you put the patient in the right position, you got all your equipment, you've palpated for the antecubital veins, they're not going to happen. There's no good median cubital either side, cephalic, basilic, nothing to go for, so you must choose another site. So, alternative sites. The inner forearm. The inner forearm works great, except the vacutainer may cause those small veins to collapse, so consider using your butterfly and syringe. The lateral wrist above the thumb, proximal to the thumb, is an option. There's a beautiful vein running right through there. And the back of the hand, the dorsum of the hand, there are great big veins running through there. The problem with all 3 of those areas, the veins will move. They will roll on you. You must use very good anchoring techniques to do the punctures. The veins will look like they want to stay still, and then they will roll out of your way right as you're about to puncture with the needle. So use very good anchoring techniques. And always remember, wherever you're puncturing, wherever you want to draw the blood from, make sure your tourniquet is around 1 hand's width above that site, 3 to 4 inches. The tourniquet should follow your site selection on the body. All right. So I hope this talk about phlebotomy and more specifically venipuncture was helpful to you. And again, this was designed for my medical assisting students to get a better grip on what we should be thinking about when we perform venipunctures in the clinical setting. Thank you.